that can be used to optimize the process. So I'll just try and set the stage for Dr. Kithsiri to do his talk. So I think before we do that, let me just go through the process and explain why it's important for this wound preparation to take place. Okay, right. So to begin with, I think it's important to just know a little bit of the biology, because without knowing how the wound heals, it's difficult to understand what the whole purpose of doing all of these various things are. Um, There are about 40, 50 slides, so I'll just run through them, and I'll stop me if anybody wants to talk, ask me questions, or I can do that later on as well. So anyway, a wound is basically a breach in the epithelium, the skin, various layers. If the skin top layer is breached, then it's called a wound. And there are two types of wounds mainly. There are acute wounds and wounds that take long to heal, so-called chronic wounds. Normally talk about a wound that hasn't healed for 6 weeks, sometimes 8 weeks, is called a chronic wound. Most of this wound healing problem occurs with chronic wounds. Now, this process is a very complex process. There are various components that are involved and that interact towards making this wound healing process a success. Now, you see, all of us would have had some form of wounds, maybe a surgery, maybe a scar, maybe an injury, and there are two ways that this will heal. One will heal with a nice linear scar. One would heal with a very ugly scar, and normally this one that heals nicely is called healing is primary intention. And if it heals a lot of scar tissue, it looks very ugly, a lot of contraction that happens. That's secondary intention. Now, if you look at the skin layer, and sort of a picture I normally talk about, we look at the various layers, and the top layer is the epidermis layer. And underneath the epidermis, there are blood vessels underneath all of these places, and a lot of human structure goes through this place. If you look outside the epidermis, a lot of foreign things going on, bugs, organisms around. And the epidermis is basically a barrier towards these bugs from not coming inside. Now, wound, like I said, is when this epidermis is breached, and therefore bugs are going to come. The first thing that's going to happen is when there's a wound, there's going to be bleeding, and therefore the blood clot that forms. Subsequently, the body responses. There are various fighting parts of the body called cells that are involved in fighting, and they start getting into this business, and they put a lot of stuff that comes into that space. And in this process, growth factors, enzymes, cells, they come into the space to try and attack the bugs that are there, try to fill the space, and ultimately, once that is done and that space gets filled, the bugs get destroyed, the top layer starts slowly coming in. And those keratinocytes, the basal membrane of the top layer, it forms a new layer, and that grows slowly upwards, and a scar is formed. So this is basically what happens. And if you look at in wound healing, we talk about 4 phases. That first phase where the blood clot happens, that's the hemostasis phase. It's a temporary wound coverage. But that wound coverage is very important because the blood and the cells in the blood are important to release various growth factors. Subsequently, there's an inflammatory phase to help cleanse the wound, to get rid of the bugs, all the cells, the cytokines, the growth factors, they come and try to clean up the tissue. A lot of stuff that happens during this phase. As time goes, there's a need to fill the space and laying down of the what's called the granulation tissue or the extracellular matrix. And for this, there's collagen that is deposited, tissues that are deposited, and this is called the proliferative phase. And finally, after all of this is done, there's a need to try and close the space. And to close the space, that's called the epithelialization phase. Once all this is done, and with time, because the wound is a large wound, there's a bit of contraction that happens, maturation that happens, the wound becomes stronger, and that's called the remodeling. So all these 4 5 things happen. So it's a continuous process, but it's also important that these phases overlap with each other. So this inflammation, granulation, proliferation, wound contraction, remodeling, all these phases happen sometimes in unison at one point, sometimes in phases. and this takes a long time, short time, based on various factors. The thing is, for whatever reason, sometimes in a chronic wound, it stops at one of these points and doesn't reach the end of the spectrum. So a wound like this, very common for diabetic wounds, it goes through an initial inflammatory phase. We find a lot of erythema. We find start proliferating. We find certain areas of proliferation. Certain areas are still in inflammatory phase. Certain parts of the wound are now contracting. There's epithelialization that happens. You can see new skin that is coming to cover the areas, and certain areas are already covered. Certain areas are still being in the inflammatory and proliferatory phases. With time, hopefully, the entire thing is epithelialized, and you can see the initial epithelialization areas are now contracting, and finally, at the end of this whole process, the wound has healed, but also remodeled itself, and the initial big wound is now a small scar. So this is normal wound healing process. And the idea of what we do all of these things is to try and get this to become a healed wound. And to do so, in part of this process, we need to make sure all the friendly, important things are inserted into that process. All the negative, bad things have to be removed. So this is what wound care is all about. And the whole idea of preparing the wound is to make sure that the wound heals like that. Like, so the whole idea we're talking about today is to try and see how we can do this. And it's important that we look at the patient in a holistic view. The saying, especially amongst the wound care specialists, that we look at the whole patient and not just the hole in the patient. Right. Dr. Kithsiri will talk about wound dressings, but I think it's important that sorry, just give me a second. It's important that we realize that these are not synonymous. A lot more that is required than just putting a dress into the wound, and that requires some knowledge and understanding, which is why these courses are taking place. So don't get carried away. Dressings do not heal the ulcers. The wound heals on its own. It's about us doing the right thing, putting the right thing, taking away the bad stuff, and making sure the wound can heal on its own. And these dressings are used as adjuncts, but you got to have the common sense to realize what is important for the wound at that particular time. Now, so the concept of wound bed preparation is about all of that. It's about making sure that we can come up with a structured program to help wounds heal. So initially, the first task is to, once you get a wound, a patient with a chronic wound, is to try and identify and treat the primary cause. Because unless the primary cause is treated, we cannot do anything else. Now, the reality is that there are various primary causes that may affect the wound from healing. Whatever you do, whatever we do, put from outside, if the primary causes have not been addressed, the wound will not heal. And the three main important things in this business is to make sure the vascular supply, the infection or the immunopathy, and the pressure imbalances are looked into and sorted out. Now, how do we do this? We have our various senses in our body, from vision, hearing, the nose, touch. It's really important we use all of these senses to try and figure out what the problem is. Right. So I just if my if the voice isn't clear, let me know. I'll try and remove the fan in case that makes the noise better. Right. So amongst these, one of the most important things is the blood supply, because unless there's oxygen, unless there's important blood cells coming into the wound bed, the wound will not heal. So how to do this? How to assess the arterial system? So clinically, it's about the pulse, feeling the pulse, and making sure you look at the pulse. There are various points of the leg, the dorsalis pedis artery and the posterior tibial artery. You can do this in a practical session one day, or there are various guidelines and pictures you can look at. But it's about finding the patient and feeling these pulses to make sure the pulse is there. Of course, there are other things like the color, various measurements like the Doppler measurement that one can take into consideration. It's not always available, and sometimes there are false negatives with any of these things. But if it looks like an ischemic ulcer because of the color of it, if it feels like an ischemic ulcer, if the color doesn't look right, it looks very pale, doesn't look bright and red and healthy collagen tissue, and talk about some of these various colors, it's important you consider a arterial problem. Various techniques are there, including scans and topography devices, but these are for high-end centers. What is important is that if you see somebody in the community, in your private practice, in your wound care practice, with somebody you suspect that the pulse is an issue, it's always best to refer them to the right people to assess. There can be a vascular problem because of a venous incompetency. If there are varicose veins, this requires a functioning of venous system. And if the functioning venous system is not there, that can cause venous stasis and chronic venous hypertension. Those valves aren't working, the pumps aren't working. Because there's a pumping mechanism required to push the blood up back towards the heart. And if any of these are not working, then still the wound will not heal because there's a primary problem that needs to be addressed. There can be problems not only in the superficial system, that's the one we can see as varicose veins, there can also be problems in the deep venous system. There can be iliac vein issues, IVC issues that one needs to be considerate about. When you look at all of these things, it's really important you consider what's called a SIAP classification, but at least if you know the various components there, you need to look at these things. Are there visible varicose veins? Is there edema? Is there pigmentation, eczema, the skin fibrotic, old ulcers that have healed? They're all signs of a venous hypertension. Sometimes, apart from venous issues, there's a picture on the right top. There's a varicose vein, there's pigmentation around the skin, there's an ulcer. It's a classic area of where the ulcers are. And you got another different kind of swelling. With different, the two pictures at the bottom of what's called lymphedema. Sometimes you're seeing this with filariasis. Different kind of swelling. Thickened skin, edematous skin, the foot's involved, the toes are involved. All these problems will lead to problems in the wound care. But it's important that these sort of things are assessed, identified, and sorted out. Amongst the other things is something called neuropathy. And what happens in neuropathy, and especially with things like diabetes, is that either bug comes into the wound and the hemostasis happens. These enzyme cells they need to come in and try and heal the wound. That's thickening of the basement membrane. Diabetes results in a problem at the capillary level. The cells and growth factors can't reach out and leave the space. The leukocytes are not functioning properly. And whatever those that do come in, they can't work as much as required. And that causes the bugs to proliferate and bugs to grow. We want the next proliferative phase to happen through, where the extracellular matrix, the granulation tissue, is deposited. This requires collagen, but in diabetic patients, in patients with diabetic neuropathy, there's a problem with the collagen formation. And the collagen is not strong and it can't hold its place and it's friable and it breaks off. We want new cells to come into the space and try and bring new tissue, oxygen, cells into the space. But in diabetic patients, there is a problem in angiogenesis, and this doesn't happen. And you therefore find that there is no real blood supply coming into the wound, even though the blood supply is sorted out. The keratins require what are called migration factors, and diabetic patients, this is disturbed. The end result is that bugs start to grow. There's wounds that are festering with pus and abscesses and leads to a huge problem. So just to highlight, before we do anything else, is really, really important that we consider looking at the primary factors that affect the wound from healing. If it's ischemic, the patient needs to have revascularization. If there's a venous issue, the patient needs venous intervention, at least until that happens, some form of compression. We'll talk about this at some point in the course. If there's lymphedema, there's lymphatic surgery sometimes, but primarily it's compression. Neuropathy, need to offload, manage the deformity, that the pressure is taken off. So all of these things need to happen initially, otherwise the wound will not heal. The wound bed preparation paradigm talks about first identifying and treating that cause. Once that is done, it's our job to see if we can heal this or not. If the wound that we feel can be healed because of the factors have been corrected, then we come out to local wound care. And the importance of spending these last 10 minutes talking about this is that there is no point in doing wound care unless that initial primary cause has been identified and treated and sorted out. As I say, the time doesn't heal all wounds, but when it comes to wound care, there is a time that does work. And it's called the time concept. I will go through a few of these things, but time stands for acronym. It stands for TIME. T stands for tissue management, I for infection and inflammation, M for moisture, and E for the wound age. So, if you look at this, you ask ourselves three or four important questions as we prepare the wound. P, what's the tissue like? Does the wound require some form of debridement? What we want is healthy tissue to happen. If you look at I, we talk about is the inflammation and infection under control. M is about asking ourselves, do we have a nice moist wound bed? And E is asking ourselves, having done all of these things, is the wound bed epithelializing? If you look at the types of tissue, and this is just a small example, but we talk about mainly four types of tissue. And it's important we try and see if the wound that we are trying to take care has any of these four things. There can be a black color, that's more of a necrotic tissue. There's yellow, there's sometimes fluffy tissue. Red is a granulation tissue, and P is epithelializing tissue. Again, I'm just reminding everyone that this is just a easy way of remembering, not that this is very strictly like this. There are lots of other types of tissue, but in general, if you know these four types of tissues and you can identify these types of tissues, that's good enough. When there's black scarring, that's necrotic. The yellow creamy stuff, it's a slough that we see, that's not pus. The nice red, healthy pink tissue, that's granular tissue. That's the kind of tissue we like to see on a wound that says the wound is healing. And hopefully, at the end of all of this, it'll be nice pink tissue as the new skin has come through. So, the idea behind management of T or the tissue is to try and remove all non viable, necrotic, infected tissue. And those tissues are the ones that impede wound healing. Debridement is about removing those types of tissue so that the wound can become healthy. Now, how do we do that? There are various techniques from using dressings, from surgical debridement, from maggots, etc. And we use these things to try and remove the devitalized tissue and get the tissue into a wound healing phase. Just necrotic tissue, just devitalized. The aim is to remove that tissue. Slough is not infection, it's actually a wound product it's a process of wound healing. It's not necessarily infected, but if it stays there for too long, it can impede wound healing. So sometimes you do try to remove the slough. It doesn't need surgical debridement. Dressings are useful enough, and if you can clean it off with the wound dressing itself, that's good enough to help the wound bed be a better wound bed. Like I said, this is the kind of tissue we want, and the idea of wound preparation is to promote this from happening. Once that happens, you find the wound will heal slowly without even a skin graft. It will heal with time. There are adjuncts like skin graft to help make it faster, but the idea is to close the wound, and that happens with this epithelial tissue. So that's the most important thing, to try and look at the tissue and see is there a requirement to remove those types of tissue and select the best method of debridement. Do you want to surgically remove it and make it a nice clean wound? That's a gold standard. We can also take away healthy tissue as well without unaware, because we can't see exactly clearly what healthy and bad tissue are. We try and use surgery, but it requires anesthesia to go to theater sometimes. So a lot of things are involved. We can sometimes use mechanical treatment, and that's about hydropressure. There are various devices that are available for this in the market, but not something that are freely used in most places. Sometimes it's not about sharp debridement, it's about the wound dressing doing all of this. And Dr. Kiss will talk about how various wound dressings can be used to try and help debridement. It's a process of autolysis to try and break down the collagens in the slough, in the wound bed, to try and get rid of all those bad stuff. Right. So once the tissue has been sorted out, and again, the idea of sorting tissue is to make sure all the unhealthy, infected, devitalized tissues are removed, and healthy, pink, granule tissue is allowed to form. The next step is to try and see what body infection, inflammation. Now, any wound that is open is going to have bugs in it because it's exposed environment. There's always going to be a host response when there's a wound, and there'll always be some form of inflammation and some form of bugs. But a contaminated wound alone doesn't necessarily seem to cause a problem. If the con- the, the the volume or the amount of bugs in the wound grow to a point, it can sometimes lead to detrimental factors affecting the wound healing. So the idea behind uh, sorting the eye out is to try and reduce the bioburden. This can be sometimes done with antibiotics given systemically, that can be either oral or parenteral, and sometimes topical antibiotics. And there are other things which can lead to less resistance, and they're called antimicrobial dressings. And Kithsiri will talk about all of these as well, hopefully, in the next hour, to try and explain to you how we can use various dressings to try and help reduce the bugs that are in that wound. It's important that we try and avoid using antibiotics, especially haphazard use of antibiotics in an irrational way, because antibiotics in one form or the other will lead to resistance. And with time, the wound will grow bugs that are not sensitive to any of the common antibiotics you can use. And if it, for whatever reason, enters the bloodstream and causes sepsis, then whole heaps of trouble, because you will not be able to control it. So using various dressings that avoid resistance is a very useful thing. Now, there are various criteria, and one can just research and search on this for the stuff that are available for this process. Uh, there is local wound infection, and that can be identified with what are called the NERDS criteria. If the wound is not healing very well, if there's an exudate that is offensive, if there's very red friable tissue, there's discolored debris, there's an odor, that normally means there's something going on, and that's a chance that there's a local wound infection happening. If the wound size increases, if there's warmth, temperature around the wound, there is a possibility of osteomyelitis. If the wound touches bone, if you probe it, the wound breaks down, the erythema, the smell, all these are features that there's a problem going on, and these can be usually some form of infection. There's really no point in just doing wound swabs, because any swab will pick up bugs. That doesn't necessarily mean that the wound is affected. We sometimes tend to take swabs and treat in any wound we find. That is perhaps detrimental. It is important that you are able to identify the wound that is infected, where the bugs, the quantity of the bugs are too much that it affects the wound healing. That is detrimental. So with time, we can talk about this as to how we identify it better and how we can use swabs and tissue cultures for all of these things. But the whole point of wound bed preparation is to try and identify infection and, when appropriate, treat it either with antibiotics, with dressings, or with debridement. Right. So, if the T has been done and the inflammation has been done, then What's important here is that we move on to the M factor, and that's about the right type of moisture. Now, moisture balance is very important. We'll all know that, even amongst ourselves, we are not too far from the wound. I mean, you realize if we are dry and parched in a hot day, then we are very unwell. We are very unwell, and that is too dry. Then the wound cannot survive in a very dry environment. At the other end of the spectrum, patients who are in heart failure, in fluid overload, in dialysis patients, lots of fluid, lots of fluid. The legs are swollen, is leaking of fluid. That's too wet. That's not good for the wound either. You've got to find the right balance between staying not too dry, not too wet, to get the optimum moist wound bed. Because that helps for a scab not to take over the wound. It helps keratinocytes to move faster. Cells can easily migrate. It traps the enzymes, the wound bed, to help with artery debridement. It preserves growth factors. It's a healthy tissue bed. And that's important because the moisture control is one of the key factors in ensuring the wound heals. So, Dr. Keith will talk about this as to how we can do this with dressings. And the dressings we use will basically depend on the type of moisture in the wound as well. And there are various types of dressings that can be used based on the type of moisture level, and must use this appropriately. So it's not uncommon that when we do wound care, we change the dressings often, because as the wound progresses, the moisture content changes, and you might use more appropriate dressings at different times. Sometimes we can, with dressings, combine these things. These things we can combine debridement, combine control infection, combine control moisture. And Dr. Case will talk about how we can do this with wound dressings as well. The end result in all of this is trying to make sure that the wound has good quality healthy tissue. There is no infection, minimum inflammation. There is a good moisture balance. Once this all happens, the epithelium will start to close. There are very rare instances, if you do all of these things, the epithelium still doesn't come through. And there are various techniques that we can use to try and uh, heighten how the epithelium closes. Again, probably too much to talk about in this forum, but whether you use various growth factors, injectable growth factors, tissue growth factors, using adjuncts like negative pressure wound therapy. So these things can be done to help wound healing process. But the end result or the end idea is to use local wound care to get the appropriate wound bed. Once that is done, with either with debridement to have the nice best tissue format, to control infection, inflammation, to control moisture, and to have the right appropriate edge effect, the wound will slowly heal. The new changes in this wound bed preparation paradigm is talking about another part which is not talked earlier in the time component. It's about concern of the patient and the family. And it's really important that once you do wound practice, once you have your own wound practice, and you realize sometimes it's not necessarily what you put to the wound, but it's necessarily about how you talk to the patient, find what is appropriate for the patient, find what the patient likes, doesn't like, dislikes, how he manages the odor, the social issues with the wound. And that's also as important as healing the wound than using the right dressing. So it's very important in this whole wound preparation that you look one at the patient holistically. Make sure the anemia is sorted out, make sure the nutrition is sorted out, make sure the right micronutrients are being in place, make sure the patient is in healthy mind, healthy spirit, but also look at the patient and the family as a holistic thing. So wound bed preparation is about combining these things. And unless these haven't happened, unless all these are not in place, you've got to make sure the primary causes have been addressed. The primary causes have to be addressed for the wound to heal. Even if the primary cause has been addressed, the wound bed preparation requires a time component. Make sure your tissue is managed, infections managed, moisture is balanced, and the edge of the wound is sorted out. And that's about holistic wound care to get the best wound bed to heal the wound. Wound care is not everyone's baby. Uh, it's not anyone's baby, but it's everyone's. There are a lot of vascular surgeons who don't share the same passion for wound care as everyone. And there are also so many non-vascular surgeons, medical officers, nurses who share a great passion for wound care. So I think more than who you are and what you are, it's actually the passion and the commitment that you have that drives all of us towards achieving wound healing. So it's a passion and commitment, not the designation that is important. Um, and really important that all of us pitch in because we cannot individually heal any of these wounds. It requires lots of people to work together. So thank you. I hope that made some sense. Dr. Kithsiri perhaps will put better clinical context into this as he talks about how dressings are useful for this process. But I hope you got some insight as to how we try and optimize the wound bed to make the better wound. Okay, that's perhaps it. I'll hand over the controls back to Samadhi and Dr. Thushan Gunarathne to continue the rest of the discussions.
Thank you, Dr. Thushan. I think who is yeah. Can you please mute your microphone? See, yeah. Okay, Dr. Thushan, thank you so much. I will now open the floor because we have few minutes left to anyone to ask questions. Is there any questions you can clarify or you can ask? Or now floor is open to anyone to ask any question related to his lecture, Dr. Thushan, because we have little time left.
Sir, excuse me, sir. How do we assess the moisture content in a wound bed?
So it's thank you. Thanks for the question. Again, it's difficult to tell clearly in on a online Zoom presentation, but it's about just seeing. You'll know, for example, if the wound looks very dry, and you see wounds that are very, very necrotic, very scabby tissue, hardly any discharge coming from the wound. The surface looks very dry. There's hardly any fluid that you can see. That's a very dry wound. Then you got other types of wounds that are always exudating. The patient will tell you, dressings දාලා දවසක් යනකොට ආයෙත් එතයි ඔක්කොම. Dressings are all soaked. ගෙදර යනකොට ආයෙත් එතයි soaked dressing එක. යන්න හම්බ වෙන්නේ නැහැ, I take it off. No, and those things, those wounds are too wet. We find what's called maceration. If you ever remember, if you go to a swim or a bath, you stay for too long, you find your fingers get very white and wrinkled. The same thing happens to the tissues around the wound also. And if there's peri-wound maceration, that means there's too much of moisture. Again, it's about the patient, the pathology, the problem. You will always find if a wound is dry, there's a real issue, a concern that the blood supply might not be enough. Which is why in ischemic wounds, it's all ischemic dry scabby tissue. If you look at venous hypertension, it's the other way. With varicose veins, the wounds are too wet. The moisture can't be removed. It stays for too long. So, how to identify a wound whether it's too dry or too wet is perhaps looking at the whole picture, looking at the patient's problem, the primary pathology. That will give you a clue. If you look at the wound nature will tell you how much the moisture is there, the quantity and the volume of the exudate, the color of the wound, the surrounding part of the wound, what's called the peri-wound skin, can give you a clue. If you listen to the patient might tell you how much of exudate happens, how offensive the smell was, how much of discharge happens. So I think you need to look at all these 3-4 things to try and put a picture into it. Perhaps one day if we do, and we're going to, once we have our online on-site course, we can talk about this. If you look at wounds, you can try and gauge this as to amount of wound moisture. And also just to talk from what you meant, the wound moisture level changes from the same wound as well. It's not as if every wound is always have the same moisture. It changes with time. Did that answer any of your questions? Was it clear?
Yes, sir. Yes, sir. Thank you.
No, thank you for that question. Yeah, please do ask questions because I am on call and I might have to run off to theatre as well. But I'll be staying online. But I'm more than happy to answer any questions now with the time I have. So please feel free to ask any questions. Perfectly okay. I'll answer as much as I can.
Sir, how can we
when we
prevent overgrowth of granulation tissue?
Sorry, say again.
How can we prevent overgrowth of granulation tissue in a wound?
Right. Okay. So overgrowth means there is increased proliferation. The wound is in a heightened proliferative phase. Now, this could be a good thing, or it could be a bad thing. Sometimes dressings we use, the if the wound has a lot of good tissue that comes, a lot of healthy growth factors, the wound will proliferate. But if the epithelialization is slow, it won't close in. So that is one reason why you can have a proliferation or a overgrowth of the wound. But that's a healthy state. You can also have this in an unhealthy state, especially with infection or inflammation of foreign bodies. Because if there is heightened inflammation, heightened proliferation, it could be the body is trying to get rid of something, trying to fight against something. So it's really important to try and differentiate these two different instances. Whether the overgrowth is because of a healthy wound that is granulating too much, or whether it is overgrowth because there is underlying foreign bodies, sometimes osteomyelitis, because the management is different. If we feel there's a risk of having underlying bone or foreign body causing overgrowth, then the management is about removing that focus. If you think the problem for the overgrowth is actually a good wound that is too healthy but not epithelial enough, sometimes it's about changing the dressing, especially if you use various commercial dressings that help proliferation, help granulation. It actually might be a adherent to the problem. Change the dressing. Sometimes you have to shave it off and allow the wound to come back to its original dimensions, because the epithelialization can't happen if there's a very proud granulation tissue. Sometimes we cauterize it, sometimes we cut it off. Various techniques are there based on the type of wound. Difficult to say exactly this, but more importantly, and thank you for the question, is that if you see overgrowth, try and figure out which one of those two problems is the problem. That is more important to figure out. Question about 82-year-old bedbound, dragging of toe, ischemic limb, difficult to bring to hospital. How to manage at home? Perhaps not relevant, perhaps to this particular discussion, but just to give a small feedback. Sometimes palliation, and that's all about palliative care, is also a very good option for some patients. Some patients who are bedbound, who are at home with a painless dry toe, is perhaps better to leave him at home rather than bringing him into a hospital and complicating things. If you do manage a dry gangrene at home, and the idea behind using in this instance is that if there is no pain and there is a rest pain in ischemic tissue and there is no infection, it's actually quite harmless. And you can use things like betadine ointments, betadine creams to try and keep the dry scab dry and not wet. If it becomes wet, that means there's infection, and then you're slightly worried because the patient can go into sepsis. There's a yeah, okay, no worries. Right. Any
Sir,
other questions? Yeah.
betadine is not exactly good for wound dressing, is it, sir?
I let Dr. Kithsiri answer this. I'm not saying no for any of them. Again, it's the context you look at. We don't always use certain dressings, certain solutions like betadine, but in the right concentration, the right format, it could be a dressing. Some people do use betadine. What is important is that to be aware as to why you're using it. For example, for acute wound, we use betadine because the idea of betadine is to try and sterilize the wound bed with infection. For a chronic wound, that might not necessarily be the case, because in high concentration, iodine actually is unhealthy, is detrimental, and it can cause impediment to wound healing. So I don't want to commit and say yes or no to betadine. It's perhaps try and figure out whether it's the right concentration and the wound is the right wound to use it. Because there are instances when We use betadine, peroxide, Milton's acidic, all sort of things, but in the right thought process.
Thushan, I have shared a photograph of a foot.
Yeah.
These are 56-year-old male, very poor diabetic control, has distal pulses, but he apparently had a some sort of a shrapnel injury. He missed, and he had some fever for a few days, and later on when he was checking, he saw a bit of a blister and some pain in the foot, but he didn't care about it, and this is how he presented. Can you elaborate a little bit on what you spoke, how to apply all that into this sort of a scenario?
Yeah, sure. No, that thanks. So I think again we stick to principles. If you go back to the wound bed preparation guidelines, I put a small flow chart. First and foremost, it's about trying identify the primary cause, and Dr. Thusi has already given us some hints as to what it might or might not be. Of those primary causes, sorting and assessing the vascularity, it could be ischemia or venous or lymphedema, for example. And if there's a pulse, it probably is, despite the wound having some black tissue, it probably means the blood supply is not an issue. I and P are the next two common things to look into. And certainly, I think there's some element of infection, probably a lot more than just a little element. And we often find if there's a lot of infection, even with an impact pulse, you get a lot of black tissue. That is because the small vessels get thrombosed with the infection. And it's often not uncommon to see diabetics with black toes, wet gangrene with the intact pulse. So infection can also lead to this black tissue that you can see at the bottom. Third thing there, and you'll find clues for this, is the smell, the odor, the patient's leg, the warmth, tachycardia, patient not eating, poor appetite. All those will help to see if there's infection going on. P, pressure is the primary problem, and of course it's in a pressure bearing point, perhaps not relevant in the acute stage, but later on when you do manage this wound at some point, you need to consider the fact that if the patient keeps on walking on this, the pressure will cause a problem to wound healing. So first of all is making sure that the important life-threatening, limb-threatening things are sorted out, and of those, V and I are the crucial things. The vascularity is a problem that has to be addressed immediately. More important is sepsis, and in this case, if we feel there's infection, local, regional, or systemic, that has to be sorted out. So first thing I would do in this instance, if the vascularity is intact, is to sort the I part out of your VIP or your primary problems, which could be a surgical debridement, because at this extent of tissue, I don't think the dressing alone might work. Antibiotics are important, taking the right samples, the cultures are all very important. How you do that would be another test discussion, but that is what you would do. Once you convert this wound or this leg into a wound where the vascularity is sorted out, the infection has been removed, then you have a cleaner wound, is a lot more healthy, where the appropriate tissues are intact. All the black, the white, the green tissues have to be removed. The eye has to be sorted out. Afterwards, you can see how you can make the granulation tissue healthier, how you can make the bugs are sorted out, how to maintain the right moisture, and later on in the phase, you look at the epithelium. So just to have a quick summary of this patient, it's about making sure the primary problem is sorted out. It's about making sure that all the friendly factors are introduced, all the negative factors are removed, and then looking at the wound bed at the same time to make sure the tissue is the right tissue, infection sorted out, moisture balance is maintained with the right dressings, and then you can perhaps get a wound that is better healed. But this is just a short description. I'm sure this can also come in and give some thoughts about it as well. But that's just me trying to put the wound bed preparation to practice. Anything you want to add to this on with?
No, that's very, very concise. Thank you very much, Thushan.
And then you'll find all of y'all in your own wound practice how we have various issues. And I always say to everybody, it's not we healing the wound heals on its own, but it's our job to make sure that the right environment is there for the wound to heal. That is the difficult part, and that requires some knowledge, some skill, some expertise, and choosing the right dressings, the right format. That's also very, very important.
So I have two questions.
Yeah, sure.
First one is when we considering about this slough tissue, do we have to remove it completely because practically it is like a bit of the challenging thing to completely remove it in the perspective of making the wound heal? That is my first question. The second one is for a wound healing perspective, we need inflammation. So if we give anti-inflammatory drugs such as NSAIDs for the patient's pain, is there a detrimental big effect on using those things on wound healing? Or if so, what is the best method of analgesia for patients with long-term wounds? Those are my questions.
Okay, thank you very much. So I'll ask second first. Second question was about analgesia and anti-inflammatory drugs. I wouldn't necessarily think that the anti-inflammatory acts of NSAIDs that you take orally would actually affect the wound healing. Certainly not to a point where it would be significant. You are right. Inflammation is important. It's something that is required for the wound to heal. If it's too inflammatory, that is a problem. And then you got to sort it out, because why you got to find out why it is too inflammatory. There's too much of discharge, too much of proliferation, too much of things happening. So it's about maintaining the right amount of inflammation. The analgesia you use probably wouldn't make an effect, in my opinion. And also things like NSAIDs are not drugs you can use long term. So in chronic pain, and there's a big problem in wound care with chronic wounds, you got to figure out what's the best type of wounds to be used. Analgesia to be used. We often don't use paracetamol, opioids, NSAIDs for long-term analgesia. There are drugs that are perhaps better, which act more for neuropathic sort of pain and neurogenic pain, things like gabalines, gabapentins, and duloxetines, which actually perhaps have a better effect, and especially duloxetine have less dependency and addictive natures to their drugs, to their behavior. Um, Fortunately, apart from ischemic wounds, most of the other wounds don't necessarily cause significant pain. It's just a chronic low-grade pain. If there's a lot of pain, you got to see if there's any other problems going on. If there's any inflammation that is overdo itself. So I would normally use drugs like those pregabalins, like gabapentin, duloxetines, amitriptylines for chronic pain. The first question was about, I forgot now. Sorry, would you mind mention the first question again?
Yeah.
Slough,
Removal,
sorry. Yeah,
complete
slough. Yeah.
removal of the
So slough, sorry, thanks. Yeah, sorry, apologies. Slough is actually not unhealthy stuff. Slough is a natural process. When there's a wound, when there's exudate, that exudate will lead to slough. It's fibrin, it's proteins, it's some dead cells, not necessarily infected tissue. So there's actually nothing wrong in keeping it. If the slough builds up, then of course it can cause problems, especially if you're trying to put wound dressings and there's a lot of slough. Hardly anything actually gets onto the wound. So in this wound bed preparation, the biofilm also is very important. It's too difficult to explain over presentation, but you don't want the slough to build up too thick and too hard, because once it dries up, it sometimes is detrimental to the wound. So you don't need to remove slough all the time, because if you do that, you're probably causing more harm, because you're damaging the healthy tissue, you're damaging the epithelium that's trying to come in and close in. If you keep on doing it every day, you might actually make the wound more chronic. So doing it surgically and removing it to a visible level is perhaps not the best thing to do. There are dressings that of course can do that, and in case we talk about this, we can use what is called autolysis, and to try and allow the slough to break off and get absorbed to the dressing and get removed on its own. That is perhaps more practical. So I'm not saying you have to remove slough all the time. It's probably wrong. I'm not saying you should never remove slough, because sometimes it is required. It's difficult to tell you when and when not, but it's the judgment of experience and expertise to decide as to when you think the amount of slough is actually going to be detrimental, because that could end up being the focus for infection to set in, for bugs to grow in, because it is still devitalized tissue that is there. I hope that's okay. That answer.
Yes, sir. Thank you.
You're welcome.
About the pain question, I can add a little bit more. The wounds you are managing should not be painful. Actually, well granulating, well healing wounds do not cause much of a trouble in the pain department. So if your wound is really painful, that means there is something happening. Either it's ischemia, or it's infection, or some pressure buildup, or something is happening. And if it's a new thing, you must definitely inquire. And if it's a ongoing thing, it's a sort of a chronic thing, again, you have to go back to basics and reanalyze. And given the, am I correct, Thushan?
Yeah, absolutely true. Very true. Very true.
So the other thing is, I mean, you should always use SOS. Only in SOS, like paracetamol, that should be your prescription for a good healing wound. And I mean, that is even not necessary. And there are 2 ladders that you should use in wound care. You should definitely use these ladders. One is the pain ladder. The other one is the antibiotic ladder. If you are going to use antibiotic, again, analgesia also the same. If those are big ifs. And analgesia ladder is the WHO standard WHO ladder. You use the simplest analgesics like paracetamol, then you escalate into NSAIDs, and then you go into mild opioids, and then later on you go into strong opioids. So it's okay to use any of those things, and even the strong opioids, they won't cause addiction if you are using for if you are really actually you have assessed and know that is like a severe pain, then it won't cause any addiction. It's okay to use. There's no ceiling dose as well. So the point is that you should use the ladder. You should adhere to the ladder, and you should manage the wound bed. You should manage the wound in such a manner that it will be free of pain, almost free of pain in quite a few visits. Okay, thank you.
Yeah, thank you so much, Dr. Thushan. And now it's time, it's 10. Now we can start our next session by Dr. Kithsiri. Dr. Kithsiri.
Yeah.
Yeah, okay. Now I will open the floor to Dr. Kithsiri. So Dr. Kithsiri will talk about the dressing selection. After that, you all can ask questions, and after that, we can have a discussion. Dr. Kithsiri, over to you. Thank you.
Thank you. Right. I hope you all can hear me.
Yes,
hello?
yes, very clear, and we can see your slides.
Okay, thank you. Actually, thank you very much for giving this opportunity to deliver this lecture. And also, I must thank Dr. Thushan for giving such an excellent lecture before my topic, and also had a very good discussion. So my part of discussion, my part of lecture is made very much easier by this. And also there will be some sort of overlapping, so I will rush my lecture. Okay. So first of all, I must say that there's no conflicts of interest because my lecture is dealing with lots of commercial preparation. I try best not to use the commercial names, but sometimes we have to use. So actually, I should declare that there's no conflicts of interest. So there's no need to say that the importance of wound care, every religion, every philosopher has emphasized. So I will rush it. And as Thushan said, wound care is a teamwork. A single person can't do this one. And also a bit of wound care economics. So if you take, these are not our data, but data of the UK, 4% of all healthcare expenditure goes to wound care. So you can imagine how much of a burden is given to the wound care in those countries. And so what about our status? So this article is actually done in 2011, written by Mr. Kumar Singh, and he says the wound care in our setting is much poor, and we need a better care. And actually, that is why the Palliative Medicine Society started this program and to promote wound care. So, so my topic has two words: wound and dressings. So I have to find a wound, a proper dressing to do a proper wound. So there are every wound is different from individual to individual. And also there are more than 3,000 commercial preparation available in the country and the world. So making a correct type of wound dressing to the correct type of wound is actually a challenge, and it's a fine task, and it comes with the very good basic understanding, and also with the experience. Right. So first of all, we will talk about the wounds a bit. So there are first we need to classify the wound, and we have to identify the types of wounds. So there are so many classifications. So I'm not going to discuss all these things. And basically, we can classify it according to the mechanism of injury, the depth of the wound, especially when you're talking about the burns, and also probably the contamination, depending on the contamination, clean, contaminated, or maybe the chronicity, or we can classify according to the etiology. So, however, I would like to classify the wounds according to the chronicity, acute and chronic, to decide on which type of the dressing that we need to use. So if you see a wound, you need to first thing is to see is whether this wound is acute or chronic. So I will talk a bit about the acute wounds because it's very important that the chronic wounds that are coming to you are initially presented as an acute wound. So the managing acute wound properly is to prevent the healthcare expenditure. So when you encounter an acute wound, you should do the thorough wound washing within 6 hours. Please don't avoid this because it can cause infection, and then this can goes to become a chronic wound, and it make a huge burden to the healthcare system. So especially if you are dealing with the surgical units, please do this one. Please wash the wound properly within 6 hours, of basically as soon as you can. So because if you don't push, these bacteria get colonized and then it leads to infection. So once you wash, then please do sharp debridement. When you wash, you can see some ragged edges, which if you those are devitalized. If you leave them alone in the wound, they can infect later. So if you can do it with a sharp debridement, taking a scissor or blade, that actually reduce the infection later on. So what type of solution you will use to wash the wound in your setting? So basically, we know most of us use saline. Some people use betadine, nothing else, and hydrogen peroxide and chlorhexidine, all these solution, right? So, and also some people use the water. So the cheaper and most available things are either water or the saline, right? So our setting actually we use saline, and I'm trying to change this practice because the current evidence says the washing with tap water is very much effective, uh, uh, and it is as same as the normal saline, and some researchers say that is much better than the normal saline, because when you use the normal tap water, you tend to wash your wound better with a high volume than the normal saline, and also it is very much cost effective. We need to think about our healthcare costs. So washing with tap water actually has not going to do any harm than a good. So if you get a acute wound, please do wash them thoroughly with either normal saline or tap water, and do the sharp debridement if necessary, right? So the take-home message: if you see an acute wound in your setting, before the washing, please don't forget to give local anesthesia, because I have seen people wash the wounds without any local anesthetic. That causes severe pain to the patient, and also you can't do the job properly. So please use some local anesthetics and anesthetize the wound, wash it properly, and do the sharp debridement. Okay. So coming to the chronic wound and our proper topic actually. So the chronic wound, as name suggested, there's a impedance to the healing process. So there are multifactorial things. I'm not going to talk about those things which you all have already heard and known. So Dr. Thushan also said about this thing, biofilm. So actually, the biofilm, there's lots of research about this biofilm, and which it delays the healing. So there are various methods to remove those things, and also there's no clear understanding yet in science. So there are lots of research going on this. So just remember about the biofilm and its importance. Okay, so these are some of our pictures with chronic wounds. This patient actually had a diabetic foot with the Rocoboton type of foot and foot ulcer. And so what you should do is to treat the cause rather than putting various kind of dressing here. So, and also this patient, actually I got from a local hospital, non-healing wound, and then for several months. And then I taken a biopsy from the edge, and it was a malignancy, actually malignant melanoma, although this does not looks like a, melanotic nevi, but it was a deposit. It was a malignant melanoma. So, and this patient actually, again, a patient with a Rockaberton deformity. Some person has thought that this area is a lump, and then he has excised and put a suture, and then the problem worst. So instead, what you should have done is, offloading. And these wounds are again common in our area, Anuradhapura. These are leishmaniasis. So if you find non-healing wounds, please take a biopsy and find the cause. And this wound actually, you can see some rolled edges. So chronic venous ulcer has turned to be a malignancy. So again, we need to get a biopsy. You have to be vigilant, and you have to suspect if the cause, if there's no healing in a wound. Okay. So these about those about the wounds, and then we'll talk about the dressings. So why we put a dressings? We need to actually to provide a rapid and cosmetically acceptable healing, and also to remove and contain the odor. Also reduce the wound-related pain, and also to prevent or treat the infection. And more importantly, throughout we discuss that the moisture balance is the most important thing in wound care and the wound healing. So to contain or control the moisture is one of the main work of wound dressing. And also to cause minimum distress or disturbance to the patient. So when you put a dressing, it should do minimal disturbance, and actually it should be cosmetically also accepted by the patient. Right. Okay. So what are the types of dressing? When you get the wound dressing, we can classify them, the various methods. So this is a very simple thing that you need to think about. So you can classify as a primary dressing or secondary dressing. The primary dressing means the dressing or the medication that you put onto the wound, which is in contact with the wound, is called primary dressings. And whatever the things we put on top of it is called secondary dressing. So so sometimes we put a different material as a primary dressing, and then another material as a secondary dressing. So the choice should be depending on the patient's factors and the wound factors. Before going on to the type of dressings, I will describe this one. This actually kind of chemistry. So if you mix a gas in a liquid medium, and it is actually, we call it a foam, right? If you mix a gas in a liquid medium, we call it a foam. For example, in a general examples, not a clinical examples, the whipped cream is a gas in a liquid. If you mix gas in a solid, it's called a solid foam, right? Or aerogels. Or if you mix liquid in a gas, it's called liquid aerosol, right? Fog or something, right? Or else any sprays. Or liquid, if you mix liquid in liquid, it is called emulsion, right? Best example is milk, right? If you put liquid in solid, it is called gel, right? Okay, so we get a lot of gels in our wound care practices. If you meet solid in gas, that is called solid aerosol. Best example is smoke. And if you mix solid in liquid, it is called sol. Right. Best example is blood and some paints, right? And if you mix solid in solid, that is called solid sol, or also called alloys. Those are commonly used in stenting, like, for example, if we mix nickel in titanium, that is called nickel titanium alloy, or nitinol is the commonest material used for the stenting. So this is just to understand the wording which you encountering during your wound care products, right? Okay, so classification of the wound dressing. It is very difficult to classify the wound dressing because there are so many, more than 3,000 wound care products available in the market, and also still coming. It's a very good profitable business, and therefore world is trying to make newer kind of wound care products, and therefore new knowledge is adding day by day. So therefore so many wound care types, and therefore classification bit difficult. However, we'll remember these things, right? We can say there are gauze or cotton dressings, right, which is common in our wards, right? Second is films. There are transparent films. Those are also called occlusive dressing. Such as, just to remind you, like opside dressing, tegaderm dressings, there are transparent dressings, right? And also there are foam dressings. Now you know what is foam is, isn't it? So foam dressing, right? And also there are hydrocolloid dressings. And also there are hydrogels, gel. And there are alginate dressings, okay? Other than that, as you know, there are Vaseline dressing or the paraffin gauze dressings, which also common in our setting. There are collagen-based dressing, like collagen sheets, which we can use for the burns or the abrasions. And also there are collagen granules, right? Some collagen granules are actually combined with antibiotics. And also there are natural products. I will come back to you. And there are advanced, very expensive techniques. Vac dressing. I think Tusita has discussed this about the vac dressings. Hyperbaric oxygen, PRP is like platelet-rich plasma, blood products we can use sometime for the wounds. And also peri-wound ultrasound or extracorporeal shockwave lithotripsy can be used for the to enhance the wound dressings, wound healing. We have used in Anuradhapura the peri-wound therapeutic ultrasound. We have this therapeutic ultrasound machine available in the physiotherapy department. So sometimes we use that facility as well. Okay, so so what factors we should think about when selecting a wound care product from all this large selection? So obviously we need to think about the characteristics of the wound, including the location, right? For example, if you dress a heel wound, then sometimes you may have to think about what kind of dressing we need to do. And the wound size, especially whether it is cavitating or having tunnelings, and also the level of exudate and pain and the odor. And also we have to think about, it is very important in the current setting that we need to think about the cost effectiveness and other factors, the social and other factors we need to think about. Please think about the cost when you're selecting the wound care products, which I have seen is one of the main area we need to discuss when we're talking about the other people. Actually, there are so many people doing the wound care, and they are using highest costly material wound care products, thinking that those costly wound care products will heal better, but it is not the truth. Sometimes simple gauze will heal better than that costly wound care products when you select the proper type of wound to this proper to the correct wound care product. So so how do you assess the wound for the dressing? So I think Dr. Thushan already discussed those things, and a bit of overlap is here. So I will rush this part. So time is one of the accepted method to assess the wound for your dressing. So what kind of dressing should be chosen to the particular type of wound? To decide that, you need to assess the wound properly. And one thing, as Dr. Thushan said, you need to think about the tissue, right? So whether this is granulation, slough, necrotic, and so on. And you need to think and you need to see whether there's an infection or not. And also you need to think about the status of the moisture, whether it is highly exudating or it is a dry wound. And finally, you need to think about the edge of the wound, right? Okay, so this again discussed previously. So when you see a wound, you should be able to identify these things. So this is a kind of nice epithelialization. You should not do any harmful intervention to these things, because it's nicely granulate and nicely healing epithelialization. So let the natural process to happen. So when it comes to these are necrotic tissue or the eschar. So these things need to go away. Otherwise, it's like a dead tissue keeping on your wound. So it facilitates infection and delays the wound healing. And this is slough. Again, the slough we have discussed previously. So we need to remove as much as possible amount of slough to promote the healing, right? And when it comes to these things, these two terminal things also you should see when you look at a wound. Here, for example, when you see, you might see there's nothing, but when you probe the wound, you can see there's undermining. So if you can see, if you can probe under the skin, it is called undermining. So your infection can harbor inside. So you got to carefully check whether there's undermining in your wound. And also you need to see whether there's a tunneling, right? If there's a tunnel in the middle of the wound, again, you can harbor the infection, and those things can actually delays the healing. So in my practice, I forget all these things and remember this thing when I see a wound. So when I see a wound, please remember to think about these 4 aspects, right? So as you all know, when you see a wound, the wound may be sloughy, or it can go in the process of healing, and finally come to the place where we want is the granulation tissue. Before the sloughing, you have the necrotic tissue. Actually, if you see the necrotic tissue, then it's no point of doing dressing. Actually, you need to do surgical debridement. So therefore, when you see a wound, please see the amount of slough available in the wound in compared to the granulation tissue to decide what type of wound dressing we are going to put. And also the second thing, and the most important thing, is to see the level of exudation. So there may be a wound with very high exudation. Those are called weeping wound. There are lots of fluids coming out, and there are wounds which are very dry. So, so these facts you need to think about. You need to think when you decide on a wound care product. And also, you need to think about the infection, right? Whether this wound is infected or non-infected, right? And the fourth thing that I'm going to think about is whether this is a special type of wound, whether it's a diabetic wound or venous ulcer or pressure ulcer. Depending on those things, we need to the type of wound care product we use is different. So please remember, when you see a wound, to see the slough exudated, whether this is infected or not, or whether this is a kind of a special type of wound. Okay, so you see a wound and you find that the wound is having lots of slough. So you need to remove the slough. So what do you do for sloughy wound? If you see a sloughy wound, and also I want to tell you that the wound can be sloughy exudating, wound can be sloughy dry, wound can be sloughy exudated and infected, right? So those you can have the combination of these things, and depending on that, we need to think about what kind of wound care product we need to use. Right. Okay. So if you see a sloughy wound, surgical debridement actually not the option, but sometimes we can use. If you see a necrotic tissue, actually surgical debridement is the option. Sometimes if you have lots of slough, we can carefully remove the slough. And please remember not to harm the granulation tissue. And also we can use mechanical debridement and also biological debridement and also enzymatic debridements to remove the slough. Surgical debridement, you can use a blade or scissor. And important message, as I said, take care not to damage the granulation tissue. So the mechanical debridement can also be done by hydrotherapy. The easiest form of hydrotherapy available is if you ask patient to get a shower, very good shower before the wound dressing. And there are other available methods, like you can take a syringe and flush the wound. And also there are expensive methods like Vasajet. This is a kind of a device where it inject the water and at the same time it suck out the injected water and the debris. Also with this simple method like wet to dry dressing, very simple, and most of the time we do in the board. Wet to dry dressing, you use gauze dressing, and you change it 2 to 3 times a day, and it is very simple and inexpensive. And this is called whirlpool therapy because it's kind of a like a bath. So water is rotating inside, and then you keep the foot immersed in the water, and then it keep the slough, remove the slough away. And secondly, we can use the biological methods like the larvae. So this is the scientific name for that larvae. The 30 larvae actually eats approximately about 1 gram of slough a day. So it is painless. An important thing is it does not invade the body. However, if you think there's a fistula, or if it is if you suspect that the wound is communicating inside the body, please don't use biological dressings. So there are commercially available packets which you can use. The problem is, which I see in our community, is the lack of compliance. It's very difficult to, explain the patients that the worm's going to work for you, and it's very difficult. But how it's going to work very nicely for the slough and necrotic things. The larvae, what the larvae, these worms do, they chemically debride, and also they remove the bacteria, and also they change the pH of the wound. And they also found to have that they release the growth factors like chemicals, and it enhance the healing, and also ingest the microorganisms. So enzymatic slough removal. There are so many enzymes available to remove the slough. For example, there are commercially available material like Iruxols, very expensive. However, this papain, urea, combination cream available. And also there are several type of collagenases. Iruxol also type of collagenases. What I see is this papol has this enzyme called papain, and we have used this in the chronic wound, and I think it's very good and very cheap method of treating in our communities. But when you see in the other countries, Western countries, we have seen these papain creams with the commercial preparations, which are very expensive, but we have freely the papain in our community. We can use them freely if you think it's necessary. So these the papain urea ointment. These are for the sloughy wounds, right? And also, one of the easy things to use is the hypertonic saline in our setting. If you see the wound is sloughy, then you can use hypertonic saline. And also, when you use these products, you need to think about the granulation tissue. If you have lots of granulation and a little bit of sloughy, don't try to use all these hypertonic saline. And also, somebody said why we can't use betadine. Actually, betadine kills the granulation tissue, and it delays the wound healing. So if you have slough, you can use hypertonic saline. And also, we can use bee honey, and it's a very commonly used one, is the Manuka honey, right? So again, I have used bee honey in the chronic wounds. The problem is the bee honey has sometimes has botulinum toxin. So if you use the bee honey, you need to use it after gamma irradiation. So in our research, we have found that it is very effective, and also it's very effective against MRSA bacteria in the diabetic wounds. So please remember again that if you want to use a wound care product, please think about the slough to granulation tissue, amount of exudation, and think about whether this is infected or not. Or fourth thing is whether this is a special type of wound like a diabetic or venous ulcer. So if your wound is, the second thing I'm going to discuss, that is the exudation. So if your wound is having lots of exudation, what will happen is your surrounding skin will get soaked. That is called peri-wound maceration. I think Dr. Thushan also mentioned about this one. So the wound edge is the one which helps to heal the wound. So if the wound edge is macerated, then wound not going to heal. So it is very important to do peri-wound care as well. So So if you see the very exudating wound, so you need to remove the exudate, right? So how do you, so what does the exudate do actually? It can cause malodor and also can cause wound pain and enlargement of wound, right? And finally delays the healing and also facilitates local wound infection. And also, you've probably seen it soil the clothing and bedding. So it is important to use, if you see a exudating wound, it is important to use a wound care dressing, a type which absorb the exudate. A common wound that I have seen in our setting, a general surgical setting, which exudates is the umbilical wounds, especially if you do a umbilical hernia repair and if it infected, then the umbilicus is a kind of a watershed area, so lots of fluids coming around, coming out. So what we do in our ward is we keep just simple gauze dressing and let it to absorb the exudate. As soon as the dressing get wet, we remove it and apply new one. We don't keep the soaked dressing on the wound hours and hours. So but it causes infection because it drags the bacterias and infections by capillary actions from the surface of the wound dressings. Okay, so what else we can use? These alginate dressings. If you search, you can have hundreds of commercial type of alginate dressing. The alginate dressings are made from seaweed weed, so they absorb lots of fluids. So the dressing is highly absorbent. It can absorb up to 20 times its weight. So alginate dressing is a very good dressing if you see a weeping wound, or if your wound is having lots of fluid. And I said that if a wound is having exudate, it can get infected easily. And also I said that when you see a wound, it can be sloughy, it can be exudating or infecting. These all three can coexist together in a wound. So therefore, these dressings sometimes combine with antibiotics. So if your wound is infected and having lots of water coming out, please use a wound care products like with antibiotic, antimicrobial impregnated. Right. And also Hadaxoma iodine. So I'll talk about a little bit about the iodine and iodine products we can use for the wounds. You can use the pure iodine to the wounds because it is very toxic and causes allergic reaction and actually delays the healing. So in clinical setting, we use two types of iodines. One is what is called povidone iodine, which you know as betadine. And also the other one is called cadaxomyidine. These are the two types of iodine we use for the wound care purposes. So the cadaxomyidine is ionized form, and actually it has an exudate absorption property, and also it has de-sloughing effect. So so it can be used, and also it's a good antimicrobial product. So therefore, the cadoxamide can be used to low to heavy exudating wounds, and also if it has an infection. So, but you should avoid the iodine products during the pregnancy or lactating woman, and also the people with thyroid diseases. And also, you know, there are some people who are allergic to iodine products. So commercial preparation, the name of the commercial preparation of cardoxamide is the idasob. It can exist as cream and powder currently. Okay, so forms. There are form dressings, right? If you search again, I'm not going to tell about the trade names. If you search the forms dressings, you can find enough trade names. It again formed from the variety of materials. It can also use to low to heavy exudating wounds. And it can also use over the granulating and epithelializing wounds, because it is very it does not cause damage to these delicate tissues. So there are, I have mentioned few commercial preparation here. And also there are gelling fibers to absorb the exudate. So there are ribbons and sheets available. One is called, I think here available is a Dura fiber. They absorb the gel, when you put it, it absorb the exudate and it become a gel. Once it becomes a gel, that means once it absorbs the fluid, you should remove it. Otherwise, if you keep it longer, then it will absorb more fluid, and it itself can cause a damage to the surrounding skin, causing peri-wound maceration and then delays the healing. And there are hydrocolloids. So the hydrocolloid dressing actually you can use for the moderate type of exudating wound. So these are arbitrary terms. So you can 100% define what is highly exudating, what is moderate, what is you obviously you can say a dry wound. This is dry. Okay. So hydrochlorics are type of dressing containing gel forming agents. Again, this, right, such as sodium carboxymethyl cellulose. So these are probably you have seen. And also there are collagen based wound care products such as collagen powder. These collagen powder actually act as a scaffold for wound healing and epithelialization and fibrosis, but it is not suitable for infected and necrotic wounds. However, there are collagen powders available antibiotic impregnated or antibiotic mixed, such as I think biotin AB, and there are maybe other commercially available products. And also, the collagen sheets available. So those can be used for fresh abrasions and burns. There are collagen sheets. When you use it, you should wash it properly to remove the preservatives and keep the wound collagen over the wound. And then you should remove the collagen until the wound heals. These use actually for the fresh acute wounds. Collagen sheets and collagen powder can be used for the chronic wounds. So these type of dressing can be used for highly exudating wounds, right? Foam dressing, which I have already described, cotton, that is the gauze, hydrocolloid dressings, alginate dressing, hydrofiber dressings, and also I didn't discuss about the ceramic wound dressings. Ceramic tiny particles, actually they absorb the exudate, and it does not cause any chemical reaction with the tissues or the tissue fluids. Okay, again, and this is our take-home message. You need to remember, when you see a wound, you should see whether it is fluffy to granulate, exudate to dry, or whether it is infected or not. or please think whether it is a special type of wound. So if it is a dry wound, now if it is a dry wound, what do you do? So you can use normal saline to make the wound dry. And also the important point that actually Dr. Thushan mentioned, that if there's a dry gangrene, please don't make it wet, because if it can cause infection and then the sepsis. So these are about the chronic wound which have dryness on the surface, right? And also the commonly you can use hydrogels, right? They are designed to hydrate the wound and promote autolytic debridement, right? When you hydrate the wound, it causes autolysis and remove the debris from the wound. The common product, I think, which you all use in Sri Lanka are probably the Intrasite gel, Pyrulone also commonly available. And also there are antibiotic mix gels such as hydrogels such as Metrogel. Those can be used for the dry wounds. So third category, if your wound is infected, then again, as I said, you need to think about starting systemic antibiotic if the infection is spreading and your CRP is increasing. And also you got to examine the wound properly to see whether the pus tracking through the tendons and through the tunnels. So you have to probe the wound and see properly. And then you can use antibiotic impregnated dressings once the pus is drained and the necrotic tissues is removed. So another problem that we encounter during your wound dressings is the odor of the wound. So what we can use to remove the odor, because it's very unpleasant for the patient and the family. Especially this happens when you do the palliative care type of thing. So you can use charcoal dressings. There are various preparation available. And also, please remember the metronidazole quickly eradicate the wound odor. So you can use metronidazole based products such as Metrogel, and maybe oral metronidazole tablets also can remove the odor. Okay, so again, same thing. So I have discussed what to use for the sloughy wounds and exudating wound, dry wound, and infected wounds. So diabetic and venous ulcers are different topics. Actually, these are very long topics, and there are a lot to talk about those things. But just to say that if you have a wound with due to venous problem, please don't just do the wound care. Please at least do the 4-layer bandaging until we do proper venous management. And for the diabetic wound, especially in the diabetic foot wound, please do offloading and what is called total contact cast rather than doing just doing the wound dressings. It won't going to help. So if you do the total contact casting, it prevents the pressure build up on the wound. So it rapidly improves the healing. And in conclusion, the acute wounds, please clean well with running water. Tap water is safer, don't be afraid. And please use local anesthesia. And for the chronic wound, think about the biofilm and think about slough to granulation ratio and exudate to dry, whether it is infected or not, and please think about the pathology. Thank you.
Thank you so much, Dr. Kithsiri. Now I will open the floor to anyone to ask questions or clarify anything. If there is anything, you can clarify. We have little time, few minutes. Please.
So how to decide the type of biopsy that we should take in a patient's wound, whether it is excision or an incision or a punch biopsy or any other biopsy type?
Oh, thank you. Right, thank you. It depends on the actually pathology what you're thinking about. For example, if you think if you see a venous ulcer with the everted edge, actually you can't do a excision biopsy. You can take you can just take a wedge biopsy, right? So it actually depends on the pathology, right? For example, if you see a tiny dot-like thing like in leishmaniasis, you can do a kind of excision biopsy. So it's the type of biopsy actually decided depending on the pathology that you suspecting, right? The most important thing is that you need to suspect a pathology rather than just doing wound care. That is the message actually we should send through. I think lots of questions asked during the last session. So there was a very good discussion there, and many questions I think answered already. If there's anything, please ask.
So how to decide whether to keep the wound open or closed?
Good question. Right. So when it comes to acute wound, actually, I always say the most of the acute wounds actually you don't have to close, because we close the wound for two purposes, main two purposes. One thing is, if there's a exudate or blood oozing from the wound, to absorb, we put a dressing. So we close the wound. And second thing is actually for the patient concerns, right? So if you close a wound, for example, acute wound, for example, if you do the surgical wound and if you close it, it actually increases the chance of infection, because when there's a moisture or the sweating underneath the dressing, the bacteria flora in the skin can itself cause infection. So if you keep the wound open, it improves the healing, right? So when you get the chronic wounds, of course, it depends on, again, the same factors such as exudate. So if you have a exudating wound, then you need to have a dressing to absorb it, right? Um, uh, and if you have a wound with odor, then you need to have a dressing with the odor control, right? So otherwise, actually, you can keep a wound open otherwise without any problem.
So, best way to remove biofilm except surgical debridement. What is the best way? Are there any dressing?
It's very difficult to say the best method. Actually surgical debridement is not the best way, obviously. You can remove it, but what will happen is when you remove it, you can damage the granulation tissue. So there are, I mean, it depends. We can't say what is the best. So as I said, you can use wet to dry dressing, right? Or you can use enzymatic dressings, right? Or you can use a biological dressing. It depends on how much of the biofilm in the wound or the slough in the wound. For example, if there's a little bit of slough and lots of granulation, if you use a very I mean, lots of very, strong way of removing slough, that will damage the granulation tissue. So you need to use a mild form of desloughing method, such as wet to dry dressing. Okay, so but if your wound is filled with granulation tissue, sorry, if your wound is filled with slough, then you can use probably a biological thing or enzymatic dressing. Right, it is the way you should decide actually.
Thank you, sir.
Yeah, welcome.
There's another question asked in the chat box. Is there an evidence of Pseudomonas infection of wounds after washing with tap water?
It's a good question. Actually, frankly, I didn't know actually that one. The evidence that I searched says it's some researchers says it's as same as the saline, and there are few research to say that it's better than saline. This actually I need to say I probably there are evidences. I mean, isolated evidence we can't take into the take it to the practice.
There's another question. What is the dressing modality for the cavitary wound? On the chat box. In the chat box.
Yeah, again, the same thing should be think about, right? Even the cavitating wounds, you should think those three, whether the cavity filled with slough, whether the cavity is having exudating, right? Or the cavity and the wound is infected. And then you need to think about the management, the dressings, right? And also then if it is so you and also I mean you can use vac therapy, all those things you can use. Those are very effective for cavitated wound. And other thing is packing, the tape packing for the cavitated wound for long duration of time. I mean, you can initially for the control of sepsis and the control of exudate, you do the packing, but excessive packing not good for these cavitatory wounds, right?
Okay. Are there any other questions?
What's the use of using rotational dressings? When do we use it?
Yeah, actually, rotational dressing actually we use for when we discuss with the microbiologists and to remove the superficial floras. So it's actually a bit of arbitrary thing. We use actually I haven't discussed with our microbiologists. So if the microbiologist recommends to use depending on our culture patterns, then we use rotationally dressings.
So what's the function of acetic acid there? Is it antimicrobial?
I think
rotational dressing?
used for pseudomonal antimicrobial action is there. These I think used for the pseudomonal. I think these Winger is used some people, but actually I have not used it in my practice.
And they're asking about the acetic acid then.
Benedict solution for wound
Benedict
care.
solution also, yeah.
I think you better search. If you search, you can take the evidence and everything for that one. Yeah, I actually don't use acetic acid and Benedict solution for my thing. Vinegar is used by one of my colleagues. Basically, that is acetic acid. So he used it for pseudomonal wounds.
So how do you
Excuse me,
know
sir.
if there is an infection in the tendon?
It's a very good question, and also is mostly missed one, namely. So the people get non-healing wounds, and people used to do the dressing every day, and the most of the time the cause is infected piece of tendon. So it's a very good question, very practical. Hello. Hello, someone is asking a question, I think.
No.
I don't know.
Accidentally, they have
Yes, sir.
the mic.
No, sir.
Ah.
I asked, sorry to use a trade name. Sir, there's a preparation called Frontosan in our setup now. There are 2 tubes with the Frontosan. How we correctly use that and the indication for use?
Frontosan, actually, I don't use, so better to use the manufacturer's advice for that. So what we should, I mean, we should use those commercial products very judicious, I mean, very carefully, I would say. So when the only thing we should know as a clinicians and scientists, we should use our scientific knowledge to do, right? So they produce so much of preparations and ask us to use. And the as I said, what we should remember is the basic principle in mind, right? So yeah.
There's
It's
another
just
question.
a thick gel.
Yeah,
That's
someone has, sorry.
It's just a another thick gel.
Yeah, I think so, but must be good, but you should use, I mean, with you have to use the evidence, and you have to find the evidence, and then and you have to stick to your basic science and principles, and then only use, right? So that is my actually my take home message. I several time use this slide, because when you use, you need to think about slough, exudate, infected none, and pathology. So so we have to think those things and use, right?
So, sir, if we have like a
Oh, yes,
very
sir.
well exudated, infected looking wound, how about a betadine dressing then?
That's not good, I think, because betadine, so slough and infected, right? So then you should think, now you need to remove the slough, and also you need to remove the infection, right? So betadine is not as ionized as cadoxuma so it's not a very good uh, I mean antiseptic in that sense, and also it does not remove the slough, right? So it's not good for in that sense, right? So
So there is no place for all these betadine ointments for wound care, is it?
ointment is for acute wounds, actually. So if you get the betadine ointments, I think it's good for the acute wounds, right?
So there's another
So how
question.
often we should? Okay, sir.
About the,
How often we should change the normal saline resin? Can we keep it do it every other day or daily?
That's again a very good question, because that's a misunderstanding we do, all right? So there's no particular time period to remove a dressing, right? For example, if you put a dressing to a exudating wound, and it become soaked within an hour, you should remove it within an hour, right? So saline dressing. So why do you put a saline dressing? So which kind of wound actually we need to put a saline dressing? So we are not going to put a saline resin to a normal saline resin to a highly exudated wound, right? we're not going to put a saline resin, normal saline resin to a highly sloughy wound, right? So, so the one indication for saline dressing is a dry sloughy wound, right? So you put you can put saline dressing on that one, and once the wound is dry, you can, dry, you can use, remove it. There's no particular set time. Then for most of the people actually do wound dressing every other day. That's not the way, right?
Okay, sir.
So there's no
Please,
particular.
yeah, go ahead, please.
And also someone asked me to say please explain about the infected tendon again.
Yeah.
Infected tendon is one of the common a common reason for not non-healing wounds, right? People I have seen putting wound care products to products and wound is not healing. And when at the end, when we see the wound, we can see infected piece of tendon. So it won't, those who have experience in wound care will know that unless you remove that piece of necrotic infected tendon, the wound not going to heal ever. So if you see an infected tendon, you need to remove it. Otherwise, it's not going to heal.
So there is another question about the fibrous tissues. Can you answer that? The chronic wounds that are fibrous without healing, are we supposed to do wound toilet to remove fibrous tissues?
The answer is, I think, no.
No.
Because for that there are other alternatives. The one is that extracorporeal shockwave lithotripsy. It is not that lithotripsy that we use for the kidney stones, but there are therapeutic extracorporeal shockwave lithotripsy for the wound care as well. And also for therapeutic ultrasound, if you do these things to the peri wounds, this it causes vascularization, right? So yeah, but I don't. If you, removing, I don't think it causes. Because I have seen in the venous ulcers, I think they refer to this one, venous ulcer with surrounding fibrosis not going to heal. So we use that peri-wound ultrasound and
Lithotripsy.
yeah.
And there's another question. The one part you have already answered about the dressing before changing. If there are undermined edges, how to proceed further?
Mm-hmm. Yeah. Yeah.
Undermining edges.
Yeah. If there's undermined edges, actually you need to see whether there are slough and infected material inside the undermined edges. You need to probe and see the extent of the undermined edge. So you need to remove all these things. And if the infection is harboring in there, you better open it up, right? You put the sinus probe or maybe a probe, and you can open it up, right? So yeah. Also, you can use the packing, but actually packing can delays the healing.
Yeah.
Okay.
I have a question about your last slide. Are you purposefully put that flower on the slide, or is there any reason? That is Gansurian.
Yeah. Actually, the Gansuria has as used for wound care products, wound care. So so it has a milk. Or what is that thing? Very effective in wound healing.
Have you tried?
They are actually not by myself, but there was a traditional Ayurvedic practitioner. Now she's the one who, and then Actually, I use these photograph of traditional things, pepper, pepper, bee, honey, all these because these are we can make evidence-based those products, right? So then we can use low cost our own wound care products so that we won't trap on those companies commercial things.
Yeah. Very interesting.
Thank you.
Very interesting. Okay. Anything else?
Yes, sir. After removing infected sebaceous cyst and after cleaning thoroughly, is it okay to put sutures to approximate?
I think you are a surgical SHO, because it's not in the books, but if you remove an infected sebaceous cyst with a adequate margin and wash it properly, and if you not got any contamination, and then you can close it without any problem, and we have seen it healed properly. But for the exam purposes and things like that, infected sebaceous cyst you should keep open. I mean,
Okay, sir. Thank you.
as long as you remove it with a very good edge, when you see, you can see a erythema around. So if you can get a good margin, so elliptical margin, and remove whole chunk without any disturbance, and then you can nicely close. Nothing will happen. That we do actually.
Okay, thank you, sir. So I have a question. How you choose a colloid dressing for wound?
Yeah, colloid resin actually it absorb the exudate. So these are the commercially available two things which I put in, right? So the important message, you first thing is, as Dr. Thushan said, you need to have a very good wound preparation, bed preparation, right? So you have to remove the necrotic tissue. You can't keep the necrotic tissue on the wound, because if you keep necrotic tissue on and then if you keep the colloid resin, it can increase the infection. So what will happen is, when you keep the colloid resin, it will absorb the fluid gradually, and it make a gel-like thing. So once the gel-like thing is made, actually, then you need to wash it and remove, right? If you keep it further, it will cause ferrule maceration and delays the healing, right? So those the each and every product has different manufacturers guidelines, so the changing things actually you need to see, but the basic concept behind is those two facts actually.
So how do you advise on bathing, sir, when the patients ask? How do you advise on bathing?
Yeah, it's actually I think every patient with a wound should bath, unless the patient having very high fever, sepsis, those things. We should always encourage patient to bath, because it prevents the infection, and it also removes the slough, and it's a known method of mechanical de-sloughing. Yeah. So and also sometime actually we, before the operation, routine operation also, we ask patient to have a bath. So those things are important thing. And also after the operations, even for the major operation, we encourage patient to bath very early.
Another two questions. Can you tell about management of infected episiotomies? Can we use hydrocolloid dressing for bed sores?
The first question, actually, I have no experience at all as a surgeon. The colloid dressing actually can be used for the bed sores, I think, because if it is exudating, moderate to heavy exudate, then you can use actually. Yeah. So is Dr. Thushan is here? Tusita is here?
Tusita is there.
I think
Tusita,
experience on this subject.
yeah.
You
Okay.
can
Anyway, are there any questions? Any further questions or clarifications? If not, we can conclude today.
Excuse me, sir.
Yes.
How do we know whether tendon is infected or not? How to know?
Good. Yeah, the tendon has the covering around, so those fascias get yellowish and gelatinous. So so that is one way, and also with the experience, actually, you can say whether it is infected or not. The health tendon is glistering and very firm, and when it infected, the glistering appearance was going there, it become yellowish, and then the fibers get torn away. And also the smells, and also the good thing is, you can see the demarcation infected and uninfected when you go the tendon. Yeah.
Okay. Actually, our annual academic sessions, which will be on 23rd of September, we have arranged a special symposia about bed sore management. So you all can attend if you wish, and there will be 3 very interesting plenary also. One with radiology, other one is urology, other one is oncology, like advanced cancers. So the annual academic sessions also you can register, and if you wish, you can attend to that. It will held on 23rd September, morning to evening at Water's Edge. So I will just post the thing in our official WhatsApp group. Then if you all are interested, you all can join. And there will be a symposia again about the bed sore management. Then I think we can conclude today's sessions. We had a very fruitful day. Thank you so much, Dr. Thushan and Dr. Kithsiri, for your valuable time, and voluntarily you have attended to these 2 lectures, and all the questions, but they have all the clarifications they have raised, and thank you so much. And Dr. Thusita Kahadua, who is our course coordinator. Thank you, Thusita, for organizing, arranging, and all the hard work. And Dr. Janaki and Dr. Kumudu for attending and doing all the administration stuff. Thank you so much. So then the next week will be the last session. So Thushan and Dr. Hilary, Dr. Thusita, we all will be there. And before the next session, I think you all have to submit the assignment or no before the next session.
No, it's actually after the session.
After the thing. Okay. Sorry.
After the session, let's give them about a week.
Okay. Sorry for that. Thank you for clarifying that after the session. Then again, we are thinking of giving you a questionnaire, like a small questionnaire about your palliative care knowledge. Also, if you can fill it if we wanted to get your, things done. So anyway, thank you once again, Dr. Thushan and Dr. Kithsiri, and others who have attended to this important lecture series. The recordings will be uploaded to YouTube as usual, so you can again go through that, and we will keep it after the sessions, another two more weeks, then we are going to remove it. So please listen to the previous YouTube, the lectures also, if you want. So thank you so much and have a good night.